صباح الخير. The topic of my presentation today will be stents. Stents, as described by Charles Stent, these are appliances constructed to cover the tissues and or the teeth for their protection or to carry medications or radiant material or to control bleeding. Nowadays, the term stent is used to describe a wide variety of non-prosthetic passive removable appliances that aid in the pre-operative planning, intraoperative guidance, post-operative healing, or serve as a temporary and therapeutic function. It has to be noted that primarily stents are non-prosthetic devices. That's to say, they do not replace missing structures. However, sometimes a prosthesis may perform a stent-like function. Sometimes the prosthesis will act like a stent. How? Like for example, an immediate surgical obturator is used to hold medications close to the surgical site during healing. Also, the immediate denture can serve as an anti-hemorrhagic purpose. Therefore, primarily they are non-prosthetic devices. However, sometimes the prosthesis may perform a stent-like function. Uses. Stents are used for many purposes. First, they carry medicaments and surgical packs to keep it in position for the required duration to the required area in the oral cavity. Second, help to control bleeding, especially in hemophilic patients. Third, protect the tissues after skin and mucosal grafts and keep them in place until revascularization takes place. Fourth, protect the teeth and the associated structures in contact sports. Also, they can carry radiant material and keep them in place for treatment of malignancy, especially in the inaccessible areas, like in the radiotherapy prosthesis, for example. Also, they preserve the depth of the vestibule after sulcus deepening and ridge augmentation procedures. 7. Promote healing through stimulation of the underlying tissues and prevent contamination of the fresh wound. Materials. There are different materials used for the construction of the stent. The most common one is acrylic resin, whether it is heat-cured resin or self-cured resin. However, the heat-cured resin is preferred because it is more stable, it contains less amount of residual monomer and therefore provides less irritation for the tissues. In addition, the resin material may be lined with a soft material to be gentle to the tissues and to provide support for other soft materials. Soft materials like soft rubber or soft resin, these materials are soft and gentle for the tissues. As we all know, silicone vinyl rubber may be used also in addition to soft resin. However, additional reinforcement of resin is usually required. That's to say, it cannot support itself because it is very soft. It needs some support from the hard resin. Third material is molding plastic and black gataperca and silicone. Those materials can be used in emergency cases where there is no time to construct a stent. These materials has the advantage of they can be used directly in the oral cavity on the bleeding area. Black gataperca is somewhat historical, not available nowadays. However, modeling plaster, which is the impression compound, can be used instead of black gataperca. Types of stents. The different types of stents can be categorized into three main categories. The first category is called preoperative and operative stents, which includes two types: radiographic stent and surgical stent. The second group is called post-operative healing device stents, and this includes the following: stent for plastic surgery of the oral mucosa, anti-hemorrhagic stent, palatal stent, cyst plug, drainage stent, nasal stent, and burn stent. The third group is called therapeutic device stents, which include habit breaking appliances, radiotherapy aiding devices, trismus appliances, occlusal therapy appliances, appliances for sleep disorder degreasing, splints, and mandibular guidance prosthesis. To start with the preoperative and operative stents, we have the radiographic stent, which is one of two types. One is used for plain radiography, and the other one is used for cone beam CT or conventional CT. Radiographic stent for plain radiography, this stent is made of a radiolucent material, which is usually acrylic resin, and a radio-opaque marker is added. Usually we use metallic bore or gataperca. This material should be of known dimension, and it is incorporated in the prosthetically proposed implant sites. That's to say, we place it in the area in which we are going to place the implant. The best area to support the prosthesis we selected, and we place the radio-opaque marker in this area. Before making the radiograph, and as you know, because it is of known dimension, we can calculate the height of the bone in this area. Therefore, this type of imaging helps only in determining the implant length to be used for the selected site. That's to say, we cannot determine the width of the bone in this area. It only shows the implant length. The second type, which is the radiographic stents for CT, usually we use a cone beam CT and not a conventional CT. The stent can be made in a similar manner to plain radiography stent. However, the radio-opaque marker should be of a non-metallic type. Why? To avoid metal streak artifacts in the CT image. If you use a metallic marker, it will give a metal streak artifact in the CT image. Therefore, instead of this one, we use gataperca. Gataperca is radio opaque and can be seen well in the CT without making any artifacts. As you see in this photo, the stent is appearing radio opaque and showing the bone underneath, and there is a channel in the middle which shows the best position for implant placement. It has to be noted that the stent can be made also completely from a non-metallic radio-opaque material, like for example using a mixture of acrylic resin after adding barium sulfate. The barium sulfate is added to the acrylic resin powder before mixing, and therefore the stent constructed is to appear in the X-ray or in the CT radio opaque and can be seen to select the proper position for implant placement. guided by the holes made in these stents. This type of stents helps in determining the implant length, diameter, as well as the point of entry, and in addition it can show the implant inclination. The second type of preoperative stents are the surgical stents, or what we call surgical guides. This group of devices are prepared over modified casts obtained from a process called model surgery. Construct a model surgery, we modify the cast obtained and construct on this cast the surgical guide. Or we can use a virtually planned model which is prepared on a 3D computer software before surgery to guide the intraoperative procedure. Examples of these surgical guides are surgical guides for implant placement, crown lengthening procedure, or radical alveoloplasty, which is made before the insertion of immediate denture. In addition, we can use surgical guides for maxillofacial and orthognathic surgeries. For implant placement, the surgical guide may be in the form of either a simple vacuum stent. This vacuum stent is formed over the cast after placement of artificial two central incisors, as you see in the photo, and it can determine the exact position for placement of implants in the place of the central incisors. Another type, we can use a transparent acrylic stent, which is constructed for partially edentulous maxilla, and it contains holes for drilling in the exact position of implant placement. Another type, we can use a transparent full mandibular stent, which covers the mandibular arch, and this stent contains an opening from the lingual side to expose the area in the interfrontal regions, and drilling is carried out through this conventional stent. The most recent types of stents is the computer guided stent. This type of stent may be constructed for precise implant placements, where drilling is carried out through the computer guided stents using precise guiding sleeves. Thus, with these stents, the flapless technique can be used. That's to say, we are not in need to open a flap, we just fix the stent on the tissues, and guided by these sleeves, it will determine the exact diameter and the exact length of the implant in each hole to be placed properly. The second group of stents, we call it post-operative healing stents. The aim of this group of devices is to promote healing and minimize the complications following the surgical procedures. They include: the first type is the stents used for plastic surgery of the oral mucosa. As we all know, many intraoral surgeries result in denuding a bony area, like in vestibuloplasty. Vestibuloplasty is a procedure in which we deepen the sulcus, therefore we can call it sulcus deepening procedure, or in case of removal of a soft tissue malignancy from the arch. Therefore, in these situations, the resultant denuded area is usually covered by skin graft to allow for better healing. However, this skin graft should be covered and protected until it takes, that's to say, until revascularization occurs. Therefore, a stent is usually required to maintain the skin graft in place until revascularization occurs from the underlying raw area, whether we can use skin graft or mucosal graft inlay stents. The stents will provide the protection of the graft and keep it in place until revascularization occurs. Otherwise, flap necrosis can occur. That's to say, necrosis of the graft and we lose it. Therefore, the stent provides a very important function in these situations. Vestibuloplasty procedures for lower reach can be done with skin grafting of these tissues, and in the same time we can place implants. That's to say, simultaneous implant placement can be carried out for a lower flat and flabby reach. In these situations, a skin graft inlay stent is used to stabilize the graft, and we use circummandibular wiring to stabilize the stent in place to avoid its movement. After healing, we can construct the final denture, and you see here the implants in the lower ridge, and you see the width and height of the ridge is very satisfactory. Also, a stent can be used after ridge augmentation. What's ridge augmentation? Ridge augmentation is any procedures designed to enlarge or increase the size, extent, or quality of deformed residual ridge. We can use bone grafts or alloplastic grafts. Alloplastic grafts are artificial materials used for grafting. These materials are used to increase the size of atrophic ridge. If we are going to make ridge augmentation, we are in need of a stent to keep the graft in place until healing. Clear acrylic resin of the rigid type is the most preferred type of stent in these situations. Why? Because it gives indication for pressure areas. Second, I can polish it to a high polishing degree. Third, it's very easy to be kept clean. Second type is Pelleted stent or Pelleted pressure plate. Pelleted stent is used after surgeries in the palate, as in tori removal, palatal mucosal grafting, removal of impacted canine, or removal of a large cyst in the palate. Functions: it applies pressure to the soft tissues after surgery to facilitate healing and facilitate hemostasis and avoid hematoma formation. You know, the palate is against gravity, so after palatal surgery, if we didn't use a palatal stent, the hematoma can make the soft tissues goes down and we get a severe swelling. This severe swelling will retard healing, and it takes a long time for this hematoma to resolve. The placement of a palatal stent will solve this problem. Therefore, this type of stents will apply pressure to the soft tissues after surgery to facilitate healing and prevent collapse, as well as facilitating hemostasis and healing. How to construct? It's very easy. An allogeneic impression is made before surgery. Then construct a palatal plate. Retention can be made with Adam clasps or C clasps. The plate covers the palate and gain its retention from these wire clasps. The plate is introduced in the mouth after surgery to apply pressure on the raw area by the help of tissue conditioning material. Therefore, we usually line the stent with a tissue conditioning material, and we keep it in place for about 2 to 7 days. Third type is called Anthropologic Stent. This type of stent is used to control bleeding after extraction in patients with high bleeding tendency. That's to say, it's used to arrest bleeding in patients who have a tendency to severe bleeding following extraction. Also, it is used in patients with clotting problem occurs in hemophilic patients as well as parahemophilic patients. As you all know, there are factors responsible for clotting. If factor 8 is missing, we call it hemophilic patients. If the factor 5 is missing, we call it parahemophilic patients. In patients with high bleeding tendencies, the problem is the lack of platelets. That's to say, the early platelet plug is not formed, and therefore the aim of this stent in such cases is to apply pressure over the extraction socket to stop bleeding until the late coagulation mechanism starts. It will press on the wound until coagulation mechanism starts. How to construct? We take an upper-lower impressions. Before surgery, impressions are poured to obtain casts. These casts are mounted in centrifugation by the help of squash bite. The tooth to be extracted is removed from the stone cast, and a layer of molding wax is adapted on the cast to cover the lingual, buccal side and top surface of the ridge. The articulator is then closed to allow the opposing teeth to touch the top of the wax. Therefore, when the patient closes on the stent, he will press on the wound. The wax is processed into clear heat cured resin or cold cured resin. Clear resin is very important. Why? Because inspection and detection of pressure areas is very easy. The stent is inserted immediately after extraction, where bleeding is controlled as the patient closes and applies gentle pressure over the extraction site. Therefore, the effective pressure will keep the wound safe until late coagulation mechanism starts. The stent gains in the retention by using wrought wire clasps to be retained in place. However, in patients with clotting defects, the situation is different. Why? In such cases, the early platelet plug is formed, but the coagulation mechanism dependent on factor VIII is not acting properly. Therefore, the aim of this stent is just to maintain the initially formed platelet plug without being disturbed, and therefore there is no need for pressure in this situation. It is different from patients with bleeding tendency. Therefore, the stent used is similar to the one used for patients with increased bleeding tendency, but there is no pressure applied on the socket, no contact between the acrylic resin anti-hemorrhagic stent and the opposing teeth. The buccal flange is extended to the full depth of the sulcus to avoid entrance of the appliance to the socket and so interfering with the blood clot formant. It is designed only to protect the socket and the clot from the tongue and to hold a hemostatic dressing in place. That's to say, we can add a hemostatic dressing in the fitting surface of the stent to help in hemostasis and the stoppage of bleeding. The rigid acrylic resin stent is usually lined with a soft resin because resin may interfere with tissue healing and irritate the tissues and disturb the clotting mechanism, so we can line it with a soft resin type. Fourth type of this group is called cyst plug. Cyst plug is an appliance which prevents closing of the opening of the cyst before complete healing of its cavity after marsupialization. That's to say, it maintains the patency of the cyst orifice. As you know, in surgery, when you have a cyst, if the cyst is small, it is inoculated completely and the wound is closed primarily. However, if we have a large cyst and you cannot remove it totally, we just remove the opening of the cyst. We call this procedure marsupialization, and we use a cyst plug to keep the opening of the cyst orifice until complete healing takes place. How to construct? The cyst cavity is plugged with a gauze or a wet cotton wool, leaving the neck part of the cavity free. Impressions is then taken and a cast is poured with a small depression representing the cyst neck. That's to say, the impression material will go slightly into the cyst cavity. Then the plug is constructed on the cast, covering the palate area and containing an acrylic projection into the cyst cavity. or if it is in the lower arch, it covers the lower arch and have a small projection into the cystic cavity. The plug must have a labial and buccal flanges with the acrylic projection not entering into the full depth of the cystic cavity. That's to say, it keeps the patency of the opening only, and it shouldn't go to the full depth of the cystic cavity. If the patient is wearing a denture, it can be used as a stent where the cystic cavity is plugged with gutta-perca or compound, then it is attached to the denture, then the plug is replaced by self-cured resin that's to say the plug is added to his old denture. Then we have to follow this technique. We have to make gradual reduction from the depth of the acrylic plug every 1 to 2 months until complete closure of the cystic cavity. That's to say, until it is removed entirely when the cystic cavity decreased in size. Drainage stent. Drainage stent allows for the escape of blood or other tissue fluids from the chronic periapical lesions when they have a fistula for drainage of infection. Therefore, in case of chronic periapical lesions, we need to keep the patency of this fistula to drain all blood, tissue fluids, as well as pus from these periapical lesions. In order to construct this stent, an impression is taken and the fistula is reproduced and marked on the stone cast. Then we bring a ready-made polyethylene tube which is inserted in the hole of the fistula, and the labial aspect of the cast is covered with 2 layers of base plate wax. Then the stent is processed with clear acrylic resin and cured in conjunction with the polyethylene tube, and then polished. And this polyethylene tube will help to keep the patency of the fistula until complete drainage occurs. Another type of these stents is the nasal stent. The nasal stent is a removable intranasal prosthesis which is used to support the form of the nose. It is in the form of 2 clear acrylic nasal projections connected together with stainless steel wire. Function. It provides support for the cartilage transplant during post-surgical healing for the correction of nasal deformity in cleft lip patients. As we said, when you have a cleft in the alveolus and the lip, it will affect the contour of the nose. After correction, we may need to place cartilage transplant. To keep this transplant in place and preserve the contour of the nose, we use the nasal stent. Therefore, it maintains the contour and minimizes scar contraction following skin grafting procedure to the nostrils. Therefore, it helps to have a nearly normal appearance of the nose after surgical correction. In addition, it can be used to widen the nostrils after trauma or burn prior to grafting procedures. So I can use it to widen the nostrils opening prior to grafting procedures. The last type of this group is the burn stent. The burn stent is a device constructed to minimize contraction of the burned tissues during healing. Usually, electrical burns are the most common type of causing burn in the oral commissures. It is very common in children. In these situations, contraction of the wound margins after electrical burns does not usually begin until about 5 days after injury. So, if you construct a burn stent, it will preserve the opening of the oral cavity and prevent the formation of microstoma. That's to say, the use of this stent before the start of wound contraction will minimize the post-burn scarring and consequent development of microstomia. You know, after burn, microstomia formation, in which microstomia denotes very small mouth opening. It will be very difficult for these patients for eating, for brushing, for making an impression to construct a prosthesis. Therefore, this burn stent is very useful in these situations. It is in the form of maxillary transparent tooth-borne prosthesis. That's to say, it covers the teeth when it is placed in the mouth and has two stout curved projections coming out from the mouth at the commissures. The third group is called therapeutic device stents. This group of stents is used to treat pathological conditions. Therefore, it's used for treatment, and that's why we call it therapeutic device stents. Most of these devices serve for a temporary period of time. The first device, we call it habit breaking appliances, like oral screen, for example. It is a stent of acrylic resin that is worn usually at night and is bounded by lips and cheek laterally and the teeth medially. Uses: the major use is to stimulate proper nasal breathing. That's to say, it is used in case of oral breathing. Also, it can be used also to control finger or thumb sucking and lip biting. How to construct: impression is taken including all tissues in the buccal and labial vestibules. Cuts are made and mounted according to the patient-centric occlusion. Then, double layer of modeling wax is adapted to the labial and buccal surfaces of the cast. Frena and muscle attachment must be freed. Then, the oral screen is processed into clear acrylic resin. All surfaces of the stent must be highly polished except that opposite to the tooth for frictional retention when we use it for orthodontic purposes. However, when we use it for other purposes, it can be properly polished. Another type of habit breaking appliances is the stent that prevents tongue biting. As we all know, repeated or prolonged tongue biting can cause soft tissue, vascular and lymphatic injury that results in edema and swelling. The swelling increases the likelihood of repeating the injury. You know, when the tongue is traumatized and swelling occurs, the increase in the size of the tongue will increase the possibility of biting the tongue. Therefore, the injury is repeated, and this will exacerbate the condition. Tongue lesions or surgery to the tongue can also cause swelling and results in tongue being more susceptible to trauma, so we can use it not only to prevent tongue biting as a bad habit, however, it can be used after surgery in the tongue. In order to prevent tongue biting for these patients, the tongue must be retained in its normal space within the oral cavity and kept from coming into contact with the dentition by using this removable stent. As you see in the first photo, it is from the lingual side. It is extending just to protect the sides of the tongue, and it is retained by root wire clasps. When you see it in the patient mouth, it covers the sides of the tongue and keep it away from being susceptible for trauma from the opposing dentition. Another type of these stents is called occlusal therapy appliances, or we call it occlusal splint, or occlusal stent, or bite plate, or bite guard. This group of appliances are very wide with different designs according to the situation in which we use it for. Therefore, any removable artificial occlusal surface used for diagnosis or therapy affecting the relationship of the mandible to the maxilla is called an occlusal therapy appliance. It's used for occlusal stabilization, that's to say, correcting the relation of occlusion. It's used also for treatment of temporomandibular joint disorders. In addition, we can use it to prevent wear of dentition in patients with bruxism. Functions and advantages of occlusal devices. The primary function of these devices is to adjust the occlusal discrepancy, therefore return the occlusal pattern to a normal position. It interrupts the existing pattern of muscle function, which contribute to painful myospasms. That's to say, the painful myospasms, the main cause of these myospasms is the occlusal discrepancy. So, when you construct an occlusal stent, it will interrupt the existing pattern of muscle function and resolve these painful myospasms. Second, it will eliminate any occlusal interference. Third, it can guide the mandible into retruded position for treatment of temporomandibular joint dysfunction syndrome. Therefore, it can guide the mandible for proper closure. Also, it minimizes the effect of parafunctional habits like clenching of teeth in bruxism and SAMSA. Technique of constructions. Impressions for the upper and lower jaws are made after proper diagnosis and evaluation of occlusion. Impressions are poured and cast obtained. Mounting of the cast is carried out using interocclusal record. Then, the articulator is slightly opened for new vertical dimension of occlusion in order to give a space for constructing of this stent. The appliance is then waxed by base plate wax and extended onto the occlusal surface, and then we have many types of these appliances. For example, we can use an appliance with a smooth flat occlusal surface for relaxation by allowing contact of all opposing teeth, in which the stent is totally flat. Or we can use indentation or ramps if the appliance is used as a mandibular repositioning device to reposition the mandibular position. Therefore, we add indentations from the opposing occlusion or ramps to help enclosure in the exact needed position. Also, we can use soft devices for patients with bruxism or clenching to distribute the pressure equally between the teeth and protect the teeth from the effect of bruxism. The third type of these appliances is called appliances for sleep disordered breathing, or what we call it sleep apnea. These cases should be diagnosed properly because we have three types of upper airway sleeping disorders. We divide the upper airway sleeping disorders into three categories. The mild form will cause snoring. The moderate form will cause upper airway resistance syndrome, in which there is difficulty in breathing slightly when asleep. The severe form will cause an obstructive sleep apnea, in which there is complete stoppage of breathing for very few seconds. So we have to diagnose the case properly. Treatment options. Different treatment options are provided for these cases. First, mandibular advancement devices. Mandibular advancement devices. That's to say, we advance the mandibular position to slightly forward position in order to prevent this sleep apnea. How it works? It works indirectly by holding the mandible and hence the tongue forward. Therefore, it keeps a space posterior to the tongue, and this space will keep the airway open. It may be stock devices or prefabricated, as if there is ready-made appliances for sleep apnea, or we can fabricate it in the laboratory. These devices are either have a single position or have adjustable positions, depending on the type. The single position stock devices consists of two rigid plastic sheets joined together into single unit. Therefore, two plastic sheets, one for the upper and one for the lower, they are joined together as a single unit. That's to say, the patient place it as a single unit in the mouth. As you see the extension in the first photo, the downward extension will keep the mandible in a forward position and therefore provide a space posterior to the tongue to keep the airway open. Adjustable stock devices, however, they have a screw mechanism in which we can change the position of the mandible in relation to the opposing one. That's to say, the mandibular advancement can be made gradually because these stock devices are adjustable. You can make it for very small amount, then increase it later and increase it later and so on. Therefore, this appliance comes in two pieces. The adjustable stock devices comes in two pieces. However, the single position stock devices comes in one piece. Another treatment modality for these cases is the tongue retaining devices. Tongue retaining devices, it works through the use of a hollow pulp and sufficient vacuum is used to hold the tongue forward. That's to say, in this hollow pulp, when the patient places the tongue while it is wet, this procedure will make the tongue to be adherent in a very slightly forward position. It's held in place by vacuum and therefore it will keep the airway open. It is usually made of non-rigid vinyl material. It's very soft, and the patient is instructed to protrude the tongue into the hollow pulp, and the vacuum should hold it in place for several hours of sleep. But we have to inform the patient that to use very small amount of water before wearing this appliance. Therefore, it will help the tongue to be held in position into the stent. The other four types of therapeutic device stents are: first type is the radiotherapy aiding devices, and this, or what we call it, radiotherapy prosthesis, and this was discussed in the previous lecture. Trismus appliances, it will be discussed later in the trismus lecture. Splints will also be discussed later in the lecture of splints, and mandibular guidance prosthesis, which was discussed in the chapter of mandibular defects. Therefore, these appliances belongs to the stent, and if I am answering a question for stents, I have to add them. them, but it we will discuss everyone in its place. Thank you so much.